the panelists, Professor Malcolm Bell, Professor Rajiv Gulati, Professor Takashi Akasaka, Samir Pancholi, Professor Akiko Takahashi, and Professor Izuki Kawa, along with my friend Dr. Ajay Swamy. So, what we have done is a picture speaks 1,000 words. So, what we have done here is, there are learning objectives. The learning objectives are calcium management in PCI, management of dissection and hematoma, management of stent failure, of course, identification and management, then management of left main and bifurcation, and identification and management of vulnerable plaque, plaque rupture, plaque erosion, and thrombosis. So here, because of the time constraint, we are going to confine our discussion to calcium management, management of dissection in hematoma, and of course management of stent failure. I hope it makes sense. So let me start with calcium management. I am going to show you one case. A 55-year-old gentleman, diabetic, hypertensive, hyperlipidemic, presented with NST-ACS, raised troponin, class 3 angina, fair LV function. This was a case in some other country where I was doing live, and I was the operator as well as interpreter and commentator, everything in that case. And this was the picture. A heavily calcified type C type of proximal LA lesion, a couple of big branches, diagonals are coming out and all this. What should be the strategy? Here, I did rota and dilated, and then the OCT picture was taken. The case was to be finished in 35 minutes. See the problems. Why? If you are doing imaging, I know young generation in this country, or even most of the country, 90% of us are dependent on the imaging interpretation done by the company person. And I think that is a wrong thing. And an operator has to be an image interpreter, and then only you can do justice. Here I thought that I have done, a good rotablation and dilatation, and stent will be fine. And we did it, and this was the picture. It was looking very scary. Why it happened, I'll let you know. What should be the strategy now? I tried optical coherence tomography catheter to push in. It simply did not go in. Then with some difficulty I could, negotiate the IVUS catheter. And this was the picture. There was a huge calcific nodule which I missed while interpreting the OCT because of the time constraint. That should not be the excuse. If you are doing imaging, you have to interpret it carefully. You have to spend good time to interpret it carefully. And then there was hematoma and, mal stent and all those things. Of course, very carefully, this was the one which I missed. And very carefully, I dilated, and I was a bit afraid to go on a very high pressure because the calcium was on the septal side, and if I overstretch the artery and if it ruptures on the diagonal side, and that can create a mess. It will create, tamponade and emergency. So instead of, MSA of 6 or so, I kept myself happy with the MSA of around 5.2. Acha, the tower team wants to show an echo report, but that we echo done afterwards. But we can see that afterwards we will not break the discussion. So this was the result. So basically, I want to know, how from the panel, what do you think? When we are managing a calcium, what are all things which we like to keep at the back of our mind? Rajiv, Ajay, and our professors, Japanese professor, if you can have any suggestion.
So I think this is one of the most difficult areas of intervention to actually have a protocolized approach, because all calcium is different and distribution is different. We have multiple tools to kind of handle calcium, but it's difficult to have one approach for all. So the best thing is to have 3 times at which we image. That's how we do it in our lab. The first, if possible, is to create a calcium map. That means the first imaging, if you're able to put the imaging, you put in the imaging catheter and then you create a calcium map. That means you map out what the thickness is, you draw the diagram in your mind, or even whoever is in the room. And this is what we've started doing. We draw the diagram, we try and map the distribution and the thickness, and we've moved away from OCT. We mostly use moved away from IVUS. We mostly use OCT because it tells you the thickness and the distribution much more reliably than IVUS, where you are left with either there is reverberation or there is no reverberation, the arc and the degree. But if you're actually able to measure the thickness on OCT, it gives you a slightly better appreciation of what you need to do. Is it concentric or eccentric? And you plan what you're going to do. Is it going to be a balloon-based strategy? Do you need atherectomy? And the second imaging is even more important. That means after we have done the atherectomy and the imaging, you put in the OCT catheter again, and then you see what you have done to your first map. What first map? How much have we changed it? And then third, you put in the stent and then do it again, and then see what more needs to be done. So if you do it stepwise, you have a clear idea in 10 millimeter divisions of this calcified segment as to what we needed to do, what we managed to do, and what we actually ended up doing, and what is the safety limit for that particular thing. However, after the second stage, in spite of whatever protocolization, sometimes you're left with doing a 1:1 non-compliant balloon dilatation in 2 orthogonal views and seeing if it is expanded enough before you actually put in the stent. Sometimes you have to give it up and say, we can't do more than this, back off for safety. I mean, that's just a framework. I'm just outlining what we do.
Yeah.
Basically, using the stent boost before in the pre-procedure, just before basically with doing the balloon, pre-balloon, and then seeing in the 2 orthogonal views. A poor man's OCT or poor man's in our condition, how would it help? Because it helps me a lot. Doing a balloon and then in 2 orthogonal views, seeing in the stent boost. What is your...
Actually, OCT has changed my perspective completely about the calcium management. And I think OCT outsmarts every single other imaging modalities as far as the calcium management is concerned. Why that I tell you? Because this has the OCT based volume index score has been devised by Fujino and Maera et al. Less than 90 degree angle, 90 to 180, that is 180 to, calcium thickness more than, and more than 180 is 2 points, calcium thickness more than 500, micron is 0, less than 500 is 0, more than 500 is 1, and of course calcium length, more than 5 millimeter is 1. So total 4, and if this calcium score is, this is the example where you can see different thickness and different diameters of the, circumferential involvement of the calcium. And this is very important. Calcium score of 1 and 2 means, the expansion even with a non-compliant balloon will be great, but calcium score 3 and 4, you have to use a technology. And this was on the basis of a beautiful seminal study done by Professor Akasaka, and this is the study. The prediction of calcium plate fracture by ballooning, a very small 61, involved only 61 patients. The study concluded that a calcium plate thickness less than 500 micron was corresponding with the cutoff value for predicting calcium fracture by high pressure ballooning. Here it means that you don't require the sophisticated technology to be used. Otherwise, you have to use whatever, rotational atherectomy, orbital atherectomy, IVL, or whatever you want, and accordingly you have to try to deal with the calcium. Why it is so important? Again, a beautiful study by again Dr. Akasaka's work. It increases the minimal stent area and stent expansion index. If you are creating a proper calcium fracture, it helps in increasing the MSA as well as stent expansion index. So how does it help us clinically? It helps us clinically because it reduces binary stenosis from 41% if there is no fracture vis-a-vis 14% with fracture, and target lesion revascularization 28% vis-a-vis 7%. A very significant difference. So lesion modification should always be attempted to reduce calcium thickness if it is more than 500 microns, and try to reduce calcium thickness by whatever modality you are comfortable with, to give as high minimal stent area as possible. Now this has been an investigator initiated study at our place, IOPUS, and I am throwing few images. 74 cases, 72 cases we have done simultaneous images of IVUS and OCT in same patient, and you can see IVUS. You can see definitely this is a horseshoe calcium. Here also you see, but you can't judge the calcium thickness very precisely. You can judge with OCT. And here again OCT gives you idea which we feel that is very important. It is heterogeneous. This is a heterogeneous sort of calcium. It will, despite it being very thick, it has a very high chances of getting broken by high pressure balloon. This is another case. You can see almost like a napkin ring calcium. This is the calcium. It's a bad calcium. This may or may not, 70% of the chance that it may not break with the balloon, and there you might have to use the technology for proper deployment and expansion of the stent. This is another example. You can see heavily calcified, again napkin ring type of calcium, but here it is a friendly calcium. It is good. You can break it with balloon and you can give a good area. This is our observation. Let me tell you, after having good amount of experience, more than 2000 OCT runs we have taken, and we now realize this of course is carinal calcium, and this is ugly. So in our lab, when we interpret imaging, OCT based imaging, for calcium we have three categories: good, bad and ugly. This is ugly. Carinal nodule is malignant. This is something which I will take, I will not take lightly, particularly when I am working on a bifurcation. And here, Rajiv and Malcolm, I like to know, even from my Japanese, here, even if I need, I feel that I have a need for two stent technique. If I can restrict myself with one stent in the main artery, and the sister artery, maybe whatever I do, simple ballooning or cutting balloon or drug eluting, whatever, I like to leave it alone. Because if this carinal calcium breaks and if the plaque shift happens, there is no way you can, give a good lumen in the side branch and you can create a problem. I like to know from you guys. Because there are so many areas, we are, again, those are gray areas and we don't know. Rajiv, what do you think?
First of all, 70 cases of IVUS and OCT is going to be huge learning for all of us. So we look forward to the paper on that.
We are going to have an atlas. Almost we are 60% through. Patel's atlas of coronary imaging. A picture speaks 1,000 words. So
Fantastic.
when this is what we want the new, young generation to know to do good to their patients, frankly.
It's going to be great. And I think what's going to be helpful, at least what I'm looking forward to seeing, is to see what you learn about IVUS from OCT. Because you can look at the OCT, see so much. I think you can then go back and look at that IVUS, same section, and maybe learn more than we currently appreciate. So really excited to see that. And I totally agree. I mean, I hadn't thought about it scientifically, but just it's a gut reaction when you see this big nodule at the carina. You know things are going to be scary for you. And if that shifts across from one branch to another, the outcome is going to be poor. And you're putting some science to it, and it makes sense.
We don't have any evidence base, but yeah, this is what I feel.
Yeah, I think this is simply fantastic. We all know that if you have calcium opposite the carina, and if you have a nodule right at the carina, both are a problem, because the calcium opposite the carina is going to shift the stent onto the side branch and occlude it, or at least make it very, very ugly looking. And calcium at the carina is going to make it very difficult for the stent to expand normally and create a decent bifurcation model that is healthy for the patient in the long run. So both need some thinking, and along with the tools, what kind of modification you need to do. And I think the Atlas is going to be great, but I mean, this is a discussion which could go on. And we
Any comment? Just set the things right, please. Yeah.
I think the bifurcation with the calcium calcification is very sometimes brought a very big problem, because recrossing the wire is much more difficult if plaque shift occurred, because plaque consists of so many calcium. So if a plaque shift occurred, it's very difficult. Sometimes we experience very difficult to recross the wire, even though we use IVL. So actually, when I use IVL in the bifurcation region with calcium, I always place a wire beforehand, because therefore, otherwise we come across a very big problem to get side branches.
Thank you. See another example. This is the case where, IVL will work very well. This type of calcium, 360 degree almost like, and uniform and all this. Here the IVL has to work, but it will consume all 120 pulses if the lesion is little longer, for sure. And then, you can get a good result with a non-compliant balloon. Professor, come over. We need you. So I was discussing, Professor Akasaka, that we have, this investigator initiative. Please, you can sit here. Investigator-initiated study, IOPUS, where 72 cases of simultaneous IVUS and OCT or the same frame have been taken up, just for a proper understanding and learning. And this is, 360 degree looking in IVUS like this and OCT like this. And I was telling that these are great cases for IVL, because it's a uniform almost and breakable calcium. Here in IVUS, somehow I am not convinced about calcium management using IVUS. I know that our Japanese friends are so fond of it, like Dr. Shigeru Saito loves using IVUS, and many of them. But understanding of calcium, is what you have with OCT, you can't have it. This is, malignant, ugly calcium. Two side, one is nodular calcium getting into calcific nodule, and another side is the, calcium nodule. You should have a luck to give a good minimal stent area in this case, or else, you keep an under expanded stent. What do you think, Professor Akasaka?
Yes, as you said, yes, we cannot measure the thickness of calcium by OCT. There are some data showing the reverberation makes the speculation of the thickness of calcium by IVUS, but it is not correct.
Yes. IVUS is a lot of presumption as far as, seeing much beyond is concerned, but here you can see it directly. This is the worst. This is the worst. And particularly this type of calcium, if you are using non-compliant balloon, you will rupture a couple of them. You use IVL catheter, there are great chances that it won't work and you may rupture it because a lot of fibrosis all around. And this is a nodule which is very sharp, and most of the pulses will be wasted. And here, this case, if I have to work on this type of nodule in a critical lesion or even otherwise in a stent deployment site, I will be using orbital atherectomy, because the mechanism, even rota you can use, but rota goes straight in the line. Orbital atherectomy moves around the circumference, so it will shave this area to keep it little more blunter, and then expanding with high pressure balloon, it may work. I'll show you the examples too. This is the worst. It's ugly, whatever you do, and if at all something will help, it is orbital atherectomy. Neither balloon, because it will rupture, nor IVL. The balloon has high chances of rupture and it won't work. And this calcium is a very bad calcium. Orbital atherectomy may blunt this sharp area, and then you can work with the technology. This is a sharp, very sharp calcium, very high chances of rupture. See, you can't differentiate in IVUS. IVUS, you think that it is a huge calcium area, but here you can see the edge is sharp, and this is a tough calcium. I need to know, what do you think from the panel? If you encounter this type of calcium, what will you do?
So I think multiple tools are there. Since it's eccentric, it's a problem. We have a publication where we used IVL for calcified nodules. The problem was it worked sometime and it didn't work, and we still don't know when it works and when it doesn't work. We just put it in and then hope that it works.
Yeah.
What used to work best for us was a rota followed by a cutting balloon followed by a rota with a bigger burr. This was done in the days before we had IVL. And sometimes the bias is not good enough for the burr to go through the area that we need. So when you do a cutting balloon after a rota, we don't fear dissections, and we go back in with a bigger burr, and that seems to create the best kind of area that we have.
Okay.
We also have multi-axial rota and a low-speed run, which we do at the end, and that is what helped us to get the best. But it is always difficult to manage.
Dr. Akasaka?
If possible, it might be better to make an ablation there because the thickness of calcium is very thick.
What will you use for ablation?
The orbiter, yes, but
Orbiter.
Orbiter might be better, but it's depend on the wire bias, right? Wire is just 9 o'clock, so rotablator may have the limitation, right? And if you audience dilate directly by non-compliant balloon, because the opposite side of the calcium is completely normal, and the balloon expand to the opposite side of the calcium, therefore may have the risk of rupture.
And even the balloon can rupture, right? Because of this sharp calcium.
Yes.
So this is orbital atherectomy. You can see a sharp nodule here, and then, after orbital atherectomy, you shave the sharp part and you get a good minimal stent area. Another example, and you see the same type of result. Now, these are the few examples, this is a non-compliant balloon dilatation, again a non-compliant balloon dilatation of a calcium. This is IVL followed by heavy pressure balloon. You can see big blocks happening because of the high pressure non-compliant balloon. This is rotational atherectomy, the pulverization of the calcium. This is, again, IVL followed by non-compliant balloon. You can see the blocks. Again, IVL followed by very high pressure non-compliant balloon, and so on and so forth. And then once you have some good cracks in the calcium, you can expand it well to get a better minimal stent area. This is a nodule, very malignant nodule, but then shaving, rotational atherectomy followed by aggressive dilatation and a good lumen area. Again, the few more examples you can see. So this is all about what we wanted to convey as far as the calcium management is concerned. Another part of the discussion I like to have is management of dissection and hematoma. Again, I like to throw one case. A 60-year-old female, hypertension, diabetes, presented with acute inferior wall MI, and see how the things get complicated, even in a very experienced center. Mild left ventricular dysfunction, PAMI to RCA lesion, and see what happens. The first injection, and see what is happening. Spiral dissection going through up to bifurcation. So what should be done first? First and foremost is, don't lose your patience. Be calm. At this point of time, if you lose your patience, and if this artery occludes, there are more than 40% chances patient will succumb to death, because major inferior wall and RVMI and cardiogenic shock situation can lead to death. Chances are 37%. Second important thing here was to find a true lumen. So put a wire in, a little bit of wire in, guide catheter out. If wire goes in true lumen, fine. Otherwise, keep their wire that way, and non-selectively giving a good shape to the wire. Fortunately, we were able to negotiate. The strategy completely changes. Instead of dilating the culprit and finishing PAMI within a short time, now the thing is to prevent ascending aortic dissection, because this RCA dissection going like this can extend proximally, and it can go right up to the innominate artery, and then you are in trouble. So first and foremost, once your wire is in true channel, this is our strategy. We have done this type of complications 3-4 times, and every time we have survived. Patient has survived with a good result. First thing is you fix the lumen or ostium, and that is what we have done. If we have fixed the ostium, it means the dissection is not going to extend proximally in the aorta. Then you take a deep breath and you make your strategy. This is what it looked like. It was a messy affair, you can see. Rather than going integrate one by one, we fix the distal part first. And this is the stenting of the distal part, and then the middle part, and the reconstruction of the artery with a clean, absolutely clean result, which we confirmed with OCT. Now, here in the OCT, if you see carefully, there are areas of hematomas. There are areas of, subictimal and intramural hematomas. The stent expansion looks good. Now, if I dilate it very aggressively, there are great chances that because of the toothpaste effect, you will find a pseudo lesion, and the things can go worse. So these are the patient. If you get acceptable good result, which has been confirmed with the imaging, you leave them alone. Bring them back after 6 months just to check whether there is any stent malapposition or not, because the hematoma by that time will dissolve, and if the stents are in some places significantly malapposed, you just expand them well, and they will expand. But there has to be a strategy for this type of cases. This is what exactly. Again, a few more examples of IOPUS, our investigator-initiated study, simultaneous IVUS and OCT. This is a big dissection. Professor, this is a medial dissection, right?
Dissection, yes.
Always to be fixed. And this is how it looks in IVUS, and more than 60 degrees. Will you like to fix these or will you like to keep it conservative? There is a hematoma. And dissection is almost like intimal, right? So what will you do? Intimal dissections are to be treated conservatively, but with this sort of hematoma, which is clearly seen here, will you like to treat it conservatively or what? Professor?
Only one image.
One more image. Anyways, there are dilemmas in this field.
This
And-
is actually the hematoma.
Yeah.
Right.
What do you think? This was our interpretation. We may be wrong. No, but I have kept few images. Run, I have. Now, when this doubt has been raised, I will go through that run for sure. Anyways, I will come back with the run. If not now, in next TRICO. What will you do with this? And what will you do with this? This is again big hematoma, right? Here it is hematoma, or lipid. See, that is what I am coming to the point, Ajay. The OCT does not see very distant thing, and many times this type of hematoma and dissection you may misinterpret as this thing. The same here. Let's see. You feel in first impression that it could be TCFA or what, but this is hematoma. Another example, this is a developing almost like a TCFA. New definition of TCFA is 75 micron thickness instead of 65. And this is hematoma. See, simultaneously, side by side. It is very intriguing at times. I want your opinion. What do you think?
This might be the hematoma, right?
Yeah, this is hematoma.
Yes.
And this is, I think developing TCFA.
You can identify the media over the 12 o'clock and then yes, right.
Cannot be. And I give you one more this thing. What is this? So the whole, sometimes, I have my interpretation that when I see this type of bulging with this type of image, I will always think that it could be hematoma with a situation, with a clinical presentation matching to it. And if it's like this straight, then I will think, and everything intact, I will think that fine, it could be developing TCF or what. But there are some areas which are still not very clear to us.
Yeah, in my experience, that kind of intraplaque hemorrhage
Intraplaque hemorrhage. Okay.
looks like this.
Okay. So was vasovasorum rupture leading to this type of picture. Okay. So when to treat a dissection, again, these are the OCT criteria: medial dissection plus minus intramural hematoma, more than 60-degree arc from the center of the vessel, more than 3 millimeter length of the edge of the stent, and then you fix. And these are the examples you can see. This is the example, the sealing of the dissection, and that's it. And these are few more examples of some very nasty type of dissection. This is intimal dissection. Clearly we can leave it alone without much of the problem. Now this is again a most intriguing area in our field, management of stent failure. And I think very little is known about it, but still we want to manage the stent failure. So stent failure, of course, is, here I am going to talk about ISR and not about the late stent thrombosis or acute stent thrombosis, subacute, no. So this is a traditional, again, most of the work has been done by Professor Akasaka and the Japanese colleagues. This is a basic classification. Rajiv, in Samir Pancholi's case, what he has shown, we were discussing homogeneous, heterogeneous, and layered. And only this area has, shown some promising result with drug-eluting balloon. Am I correct, Professor?
Yes, only
Homogeneous.
homogeneous and also the high scatter.
High scatter.
Yeah.
Yeah.
Second. From
Yeah.
left.
Second. Yeah. So all other, but this is a new classification. I like to know your view on this. Type 1, 2, 3, 4, 5, 6. Type 1 homogeneous, type 2 almost like layered. This is a mottled appearance. This is partly the stent is seen, otherwise it is not seen. There are different areas of different optical intensity, and here there is some protrusion. It could be a nodule or thrombus or whatever. So what do you think? This makes the things even more complicated.
But generally speaking, the type A is very DCB is very useful, but and type F might be we need.
This A is type 1. This is 2, 3, 4, 5, 6. That is what they have described. Yeah.
Yeah, there are no significant difference by DCB and normal balloon, right? But F might be some nodular calcification. Therefore, we need an ablation, or it's depend on another condition. But IVL should be very useful.
But first of all, I don't know. I know that the restenosis with stent is high. If you do DCB or you do whatever or cutting balloon and you create dissection, will you be comfortable leaving that dissection just like that? Or will you like to stand? Rajiv, I want to ask you this question.
Yeah, for those of us that did not grow up in the balloon era, we feel very uncomfortable leaving a dissection in general. And I think the same is true just looking at this. It's going to take a new learning to leave these alone.
So balloon era, then balloon and stent era, and then stent, the bare metal, and then the drug-eluting and whatever. I have gone through everything, but I think Malcolm is the senior most person. So we'll like to know from him.
Malcolm published the first paper on dissection classification back in the 18th century, I think it was.
Oh, come on, I think it was the 19th century. This is bringing back memories. First of all, I feel that I'm just very unsophisticated here, but I'm sitting next to Professor Akasaka here. So I think there are so many things here that, first of all, I was not familiar with this classification, to be honest. And clearly, you've shown some fantastic examples of, the comparison between IVUS and OCT. And as so many times in my life, and I think, for everyone in the audience, always be prepared to just listen to how other people do things. And I have to confess, I've been a big user of IVUS, and but from what I've just learned just today, I can see that I need to be doing more OCT. But then at the end of the day, you need to be able to prove that what you found on OCT, and then the action you take actually makes a difference to the patient, and I think that's what we need. And in fact, I think the comments made by our other panelists here at the beginning were very, very helpful. I mean, it was a really good framework and a lot of really good advice there. Actually, just going back, because Dr. Galati just referenced my paper, and that was a study, that was in the pre-stent era. And although stents were just coming in, and the question was, did we need to stent everything? And we studied, in fact, the paper is so long ago, I can't even remember how many patients we had, but we looked at all of these dissections, and there were many dissections that we just left alone because we didn't really have the tools, and we weren't that keen to be putting stents into everyone. And as I said, this was in the early days of stenting. But one of the key risk factors for subsequent occlusions or MACE was if the vessel actually had occluded during the intervention. And that was probably the most powerful one. And then it was really the degree of stenosis. These were just angiographic studies. There was no IVUS, there was no OCT. And in general, a lot of these dissections actually just healed themselves. And from time to time, we will show our colleagues and particularly our fellows angiograms showing quite significant dissections. And they were left alone. And the patient came back months and particularly years later. And sometimes there was actually no sign at all of those dissections. Some was healed, and there was some residual evidence. But of course, those were angiograms that were performed in the pre-stent era, and it was just to show the natural history. And most of these do well. But I do worry about that's why I asked this question earlier today. That you see that little intimal dissection, and typically on an angiogram, you might not have even seen that. And so now we're going to be thinking about, what am I seeing here? Now I've got to do this. I said I'm a little unsophisticated in comparison to many people in this room. My approach to calcium has just generally been rotablator, and IVO with the appropriate anatomy in terms of length. So, and as I look at these, I realize I have a lot to learn about OCT. But I'm also pleased to hear that you were hesitant, in some of these. What is this? And as I look at these, this is not another gold standard in cardiology, because some of these images, they're not so easy to interpret. And I'm looking forward to even better imaging, with more precision and much easier to interpret. Anyway, that's a sort of a long-winded thing. You invited me as the most senior person here, and I'm just confessing my ignorance here, but also being open to learn some new approaches.
Great comment, Malcolm, and very thoughtful, of you. This is a great stent result. You see here, it is almost like homogeneous type 1. This is also almost like homogeneous type 1, type 1, type 1. This shows some part of the stent is missing, and this is the area, type 4. This is almost like layered type 2. This is a, sort of a neoatherosclerosis, lot of fat, and the stent partially seen, not seen, type 4. This is again, the areas of different intensity, but part of the stent is also seen. So I will grade it as type 5. And this, this one.
Calcium, right?
Pardon?
Calcium.
This is calcium. So
yes.
it is very old ISR, right?
Yeah, right.
Okay. So which category you will put this?
F.
F.
All right.
But F is classic F example is this protrusion.
This, also the calcium,
this is type 6.
Yeah, right. But very similar.
So I think sometimes we make complex things simple, and sometimes we make simple things very complex. I personally feel that ISR is becoming more and more complex day by day.
Could you back to the original ISR view, right?
Yeah.
Because I would like to say that most of the main cause of ISR is under expansion. Therefore, you can back to the original A to F image, right?
Yeah. Which one? Previous one?
Previous one, yes. Yeah, also this as well. Yes, it's back to the.
Okay. This image.
This one, yes. You see the A and C. You can identify the huge medial area tissue, right?
Mm.
So this indicate under expansion. So if you treat this, you try to use a bigger balloon, right? And not only instant hyperplastic tissue treatment, but also the.
This is a great learning. Yes, this is a great learning. Do you think, can I presume that there may be a hematoma at that point of time and the stent looked good, and then hematoma dissolved, and then there is some malapposition leading to ultimately restenosis, or simply under expansion, and this is a restenosis.
I think so. The recent histological yes analysis. Initially, the instant stenosis tissue is mainly proteoglycan, no collagen, right? And then later collagen comes in the proteoglycan tissue. It becomes some scatter like C or D, right? And then much more collagen comes, the type A.
Yeah.
Right.
So this is, I think, all about what we discussed, and these are again the cases, eye opus cases. This is, part of the stent is seen and not seen, maybe type. This is definitely type 4, right? Only this part of the stent is seen. Okay. Now, two cases I like to show before concluding the day. Role of imaging in spatial situation. When I say spatial situation, either I have created complication or I just missed a major complication. And this is a 59-year-old male, diabetic, hypertensive, PCI to LAD lesion done before 4 years, presented with acute anterior wall MI and severe LV dysfunction. I showed this case in our master class of, imaging and physiology, TRICO. So this was the picture. Sorry. This was the picture. Acute anterior wall MI, stent in the proximal part, and it looks like this. I need a view from the panelist. Rajiv, what do you think about this proximal area at the bifurcation?
Yeah, this looks like a very ugly acute lesion. Right now, just looking at the bifurcation itself, the circumflex origin looks spared, and based on the angiogram alone, I'm thinking it doesn't look calcified either, and one might think that a single stent approach, but here's where I would personally do IVUS here to characterize this and understand it.
Now the only issue is patient has presented with anterior wall MI. How can you explain this? I mean, I don't see anything all around. Here, this is the stent in the proximal area, which is not visible. I will, before, I'll show you the result first. I could negotiate, dilate, stent it, and then we saw it and everything was fine. We accepted the result. But this was the situation to start with. I'm just giving you the cartoon. My wire and then the OCT catheter as well as IVUS catheter. This is eye opus. Both went through the strut. And then I saw it on both. I'll show you. Then I found the true channel and where, in the true lumen, and I went in, and then we fixed it with the balloon and stent and everything. So it was an aneurysm, actually, developing aneurysm. The typical, we have cases reported with, particularly with, the drug-eluting stent in some of the cases. So this, just concentrate on the, this central lumen. It is now outside the lumen, in aneurysmal area. Now it is in the left vein. Same IVUS image you see. It is in the LAD. The catheter moves, IVUS catheter moves in the cavity. And this is LAD. And now it enters the left vein. Now, had I performed intervention just like this, what would have happened? Here, dilatation and stenting. 1, 2, and 3 layers of stent in an aneurysmal segment means sure subacute thrombosis or some major issue over there. So this was here in this case because, we interpreted it very carefully. The imaging was a savior. And I confirmed with the both imagings. You can see this is in the sac, this is in the sac, And these are the true lumen images, side by side. And last but not the least, I think many of you might have seen this case, aneurysm management. First, we did, and it was published already in Jack case report, the first issue at that point of time. A 25-year-old lady presented with ACS, inferior wall changes, raised troponin, a selective angiogram showing a giant aneurysm in the proximal right. And we have got every single, MRI done for every single vessels, particularly brain and abdominal vessels. They were normal. And then actually she moved around in different parts of the country to 6 different centers, and every center advised surgery. She is 26, awaiting her marriage after 6 months. And she came with high hopes that you fix it up on cath lab. How to do it? Now we had Papyrus with us, covered stent. Papyrus has his limitation. We measured the length of the aneurysm. Graphmaster and Papyrus both, covered stents were available up to 26 millimeter length. And this aneurysm length was quite long. What to do? Here, my colleague Sanjay came out with a brilliant idea. I was wondering how to, we use this and we can use 2 wires, and we just try to push inflate the stent distally, covered stent, and then push it in proximal. But in that case, if I miss the segment, it can create a big mess in a very young lady. He came out with a brilliant idea that we deploy a 38 millimeter long stent. So Giant's expedition was deployed, and we created a platform. After creating the platform, we deployed 2 Papyrus, keeping a very small overlapping back to back. And you can see the aneurysm disappeared. We did OCT. This is the result. We did OCT, and you can see here perfect distal deployment, and here you see the blood beyond the cover, and then again the normal segment. Full moon eclipse. We brought the patient back after 9 months. Angiogram, perfect. We did OCT. Because this was very important. Covered stent has high risk stenosis. Everybody knows that. But here it was acceptably, we can genuinely accept there was some proliferation, but it was an extremely acceptable type of proliferation. And you can see very little proliferation. The patient after 3 years doing perfectly all right. Thank you very much for your kind attention. This was, a great day, although it was a difficult day. And, I'm very, very thankful to all my international guests, national guest friends, as well as the participants to get yourself involved so well. And tomorrow we are again going to have a very power-packed day in the first half, where we are going to show you some very exciting cases at our and lot of calcium management and some anomalous coronary intervention and all those. And all young guys, please, remain present in the afternoon session, because there are 9 talks by world authorities on their subject, and they will be genuinely great talks to listen to. Thank you very much. And we assemble for the gala dinner and having a very relaxed evening.